Mute here, so mute, mute. Hello, good
Hello.
afternoon, and thank you for joining us. My name is Thamer, and I'm the lead on a project funded by the Patient-Centered Outcomes Research Institute to report on findings from several large, recently completed research studies that are related to dialysis care. So welcome all to our first patient webinar entitled Depression in Patients Undergoing Dialysis. First, let me introduce today's speakers. Dr. Mehrotra is a professor of medicine at the University of Washington. He's the section head of nephrology at Harborview Medical Center, and he's editor-in-chief of the Clinical Journal of the American Society of Nephrology. He's a physician scientist, and he does clinical research focusing on improving symptoms experienced by patients treated with dialysis. Bob Barakis is going to present the patient perspective. Bob's been on hemodialysis for 3 years, and he dialyzes in a unit run by a local not-for-profit in Puget Sound. He participated in a clinical trial, the ASCEND trial, that's going to be discussed in this webinar, and he received talk therapy during the clinical trial. And after he completed participating in the trial, he also received treatment for depression using drugs. While you're listening to the presentation, please feel free to write down any questions. At the very bottom of your screen, you should see a Q&A button. And so please click on that and at any point ask us questions, and we will try to answer as many as possible at the end of the presentation. Dr. Mehrotra, please get started with the presentation.
Thank you. Thanks for the opportunity to present. I'm going to talk about depression in patients undergoing dialysis. So I've been taking care of people treated with dialysis for about 20 years now. And the first thing I want to acknowledge is that the plate of people with kidney failure is full. Most people have other health problems such as diabetes, high blood pressure, heart problems. There are many people that are legally blind or have had an amputation or need help with activities of daily living. They are admitted to the hospital, if you look at the entire dialysis population in the country, on average about twice a year. And a dialysis patient on average spends 12 days every year in the hospital. And if they're admitted to the hospital, 1 out of 3 chance is that they will be readmitted within 30 days. So there are numerous transitions in care. So sometimes they are at home, sometimes in a skilled nursing facility, sometimes in a dialysis unit. And I would wager that neither the patients, and it's not the fault of patients, it's the way the healthcare system is built, that it is very challenging to handle these transitions well and safely. And many people on dialysis report a low quality of life. In addition, the treatments we have for kidney failure ask a lot from patients. If it's in-center hemodialysis, it's done 3 times a week. 3 to 4 hour treatments, they require 4 to 5 hours of commitment. Peritoneal dialysis treatments are every day. Home hemodialysis is 5 to 7 times a week. In addition, we have a lot of limitations on the diet. Cannot take too much salt, cannot take too much potassium, not much phosphorus, not much fluids, but have to eat a high protein diet. So this is very difficult on top of the treatment. And then there are a bunch of medications we ask people to take. This is a simple study that we did in 3 different parts of the country. And all we asked people was to count the number of pills they were asked to take on a daily basis. The average number of pills a person was asked to take was 19. Half of them were phosphate binders. So a person on dialysis takes on average 19 pills a day. There are many people that take more than 19 pills in a day. This is again in top of the limitations on their schedule because of the needs for dialysis and the limitations on the diet. So the challenges become greater when people also have depression. So let's first ask this question, which is an audience response question for people to be able to answer. What percentage of dialysis patients at any point in time suffer from depression? Is it 5%? Is it 10%? Is it 30%? Is it 60%? So you can answer now. Okay, so 3 out of 4 of you say it's 30%, and that is correct. So 30% of people do suffer from depression. This is, I'm not going to go through this complex chart. What I want to point out using this chart is that this has been studied extensively. If you pool the results of about 200 different studies, which enrolled about 50,000 people from around the world on dialysis, the results show that at any point, 1 out of every 3 person on dialysis has depression. So the question, of course, is always asked in people that are otherwise ill, that are not on dialysis, how common is depression? In adults, it's estimated that about 8% of people have depression at any time. This is over 30%. So the prevalence of depression in people on dialysis is 4 times as much as people in the general population. So it is very common. Let me ask our next whole question is, what is the difference between depression or sadness? First is depression is a disease, while sadness is a normal emotional state in humans. Sadness is short-lived, but depression is persistent and long-term. There are many types of depression, while sadness is something normal and specific to recent circumstances or events, or all of the above. Please answer the poll question. All right, so 80% of you chose all of the above, and that is the correct answer. So depression is a disease, and there's of course criteria that we use to diagnose depression, but there are 3 key components to the diagnosis. First is that the person has a depressed mood, or they lose interest or pleasure in daily activities for more than 2 weeks. That mood represents a change from a person's baseline, and it results in impaired functioning, whether it is in social settings, or in occupational settings, or in educational achievement. So a change from the baseline, the low mood is persistent for 2 or more weeks, and it interferes in the ability of a person to live their lives in multiple domains, whether it's the social, occupational, or educational. Like we said, what it is not, like this was already on that poll question, it is not the same as feeling low for a few days, say when you are access clots or you are ill. This is when the low mood persists for 2 or more weeks. People who get depression, it is not representing a weakness in their character. This is a disease, just like problems with the kidney or problems with the heart. People have actually measured the concentration of chemicals in the brain, and the concentration of chemicals in the brain are altered, and that is what causes depression, and it does not reflect on the person. And I would argue that if you feel low or depressed for 2 or more weeks, let your doctors or other members of your health team know. We're going to ask, again, what are the symptoms and signs of depression? And you can choose more than one to be correct. Always feeling sad, loss of interest, changes in appetite, trouble sleeping, loss of energy, feeling worthless, difficulty thinking, thoughts of death or suicide. Okay, so it is all of these things that can happen in people that are depressed. So it is, all of them would be correct. All 8 of these symptoms are manifestations of depression. The first point, the point I've tried to make repeatedly is that depression does not just go away. This is a study in which people completed a questionnaire about their mood every month. And so each one of these components of the chain that you see is every month. What is remarkable is that you can classify people in where the mood is the same way month after month. So that people whose depression scores are low, which is group 1, it remains low. And in people, for example, groups 4 and 5, it fluctuates a little, but it generally remains high. So it does not just go away without treatment. People's mood generally remains the same month after month. If the mood is, and I use the word mood in a medical context. I am not using the word mood in how, on your whims. It is not your whim that makes you feel good or feel low. It is where the chemicals in the brain allow your mood to be. And there are people whose health is such that they can remain not depressed all the time, and there are people that are depressed all the time. Said it twice, let me say it the third time, without treatment, people's mood generally remains the same month after month. It does not go away. And it is challenging. It is, I started off by saying that the plate of people with kidney failure is full. There's a lot that a person with kidney failure needs to do to remain healthy. They have to show up for dialysis. They have to be mindful of their diet. They have to take all of their pills. If they're admitted to the hospital, and then they have to settle back into a new environment, and then they're discharged. In people that have depression, it is, they are not able to do all that they need to do. People call that compliance or adherence, that, oh, you're non-compliant because you are not doing what the doctors are asking you to do, but that is a manifestation of depression. It makes it difficult for people to show up for dialysis. When they show up for dialysis, to complete the full treatment, to take the medicines like you're supposed to, or pay attention to every detail about your diet. So the point of it is that just to reinforce what I'm saying, is that it is important to recognize that depression is present because it will not go away. And if it does not go away, it'll make it harder for people to take care of themselves, to do all that they need to do for kidney failure. Let me just invite our patient, Bob, and what I would hope that he would be able to address. So Bob will get to the conversation about your experience with treatment later, but it'd be important for you to share with the group your views about depression as a disease, whether it goes away or not. And there is a stigma that goes around the diagnosis of depression that people are not willing to acknowledge, and how you navigated that. So go ahead, Bob.
All right, well, I agree with everything you said, because everything you said just a minute ago pertains to my situation. You know, I've been on kidney dialysis for like 3 years, and you're right, it is a big commitment, and you got to follow everything they say. And, you know, it's like I lost a leg earlier in 2007. So, you know, that started with my depression. And then I found out I had kidney failures in about 2010. So it's like, you know, it was okay for a while, and then like 2015 or 16, I had to go back to the doctor. I was admitted to the hospital, and you know, he says, your kidney, you only have 10% kidney function. So, and I said, well, what do I do now? Well, we tried to hold it off as long as you could, but now you got to go on dialysis. So I've been going to dialysis for the last 3 years, and, you know, it's just like, that's my life. You know, my life is dialysis, coming home, and, you know, believe me, when you're on dialysis, it wipes you out after your treatment. And you know, you have to take a nap, and just like a routine every day. And if you don't take a nap, then you're just like wiped out for the rest of the day. So, you know, that's what I have to do, you know, and I have to take my pills. I have to, you know, make sure I have my nephrologist who comes to the kidney center. So I talk to him twice or 3 times a week. So I'm good at that. But, you know, it's just, depression, when you're on dialysis, depression is going to happen. And, you know, when I started the study, they gave me the pills, and I was okay for a while. And then it's just like, I don't know, if you walk a mile in my shoes, then you'd probably figure out, well, this is what an average person goes through. You know, when they have dialysis, you feel, and then you start getting depressed, then you feel like it's your life is over with. But, you know, being on dialysis, it's keeping you alive until you qualify to get a new kidney. You know, there is hope, but, you know, you got to get up, you know, like I go Monday, Wednesday, and Friday dialysis. So I have to get myself up in the morning, 2:00 in the morning, because I got to be there by 5. And it's like, you know, you got to do it. It's a commitment. And, you know, you're knowing that you go and you're getting up in the morning and going, it tries to get you out of the funk because it knows that it's keeping you alive. And that's basically how I feel about everything.
Can you just address the issue of stigma? Like you know, as a part of the study, we diagnosed you as having depression. Was it?
Yeah, they diagnosed me as having depression because there was signs that I was feeling like I was going to do harm to myself, or, you know, or any on the other parts. But that was one of the main parts. And then you just feel like you're shying away from your family. You just want to be left alone. And it's just, that's not who I am. I said, okay, I talked to one of the ladies who did the depression study, and she said, okay, we're going to try you on these pills. And after the pills were over with, then I went to my doctor, and then he prescribed me for the pills. And, you know, so far, everything since I've done that, everything's been good. It's just, it's not going to go away. It doesn't go away. You have to work at it.
Right. Thanks, Bob. We'll have you come back and talk a little bit more later on in the hour.
Okay.
Thank you. So what have I said so far? Just to summarize, many people on dialysis are depressed. Depression does not just go away. Depression makes it hard for patients to do all that they need to do to manage their kidney failure. So what more should you know about depression? What I'm going to talk about more is if depression is not treated in people on dialysis, it leads to more problems with people's health. In people with kidney failure, depression can be difficult to diagnose. And depression is treatable, and it reduces suffering. So let's begin with the health consequences of depression. If any of you has had depression, or if you've been around people that are depressed, like Bob was sharing a story with us, it in and of itself causes considerable suffering. It is not good feeling miserable. It does not feel good not to want to kill yourself. It's just, I don't think there have to be other physical consequences of depression for this to be meaningful. Depression itself causes considerable suffering to people. But the consequences are even greater beyond the low mood when it happens in people with kidney failure undergoing dialysis. This is a complicated slide, but I want to just make the key point here. If you look at this column on the left, essentially is where the people's depressive symptoms are. This is the middle panel here is the depressive symptoms. What this is showing is that people that are depressed are more likely to miss a dialysis treatment. So if you feel like if it happens often that you wake up in the morning, you do not feel like going to dialysis, and then you don't show up for dialysis, it could be because you have depression. There are similarly, in people that have high depression, they are more likely to ask their treatment to be cut short. That it just is difficult to sit through treatment for 4 hours, 3.5 hours, however long it's been prescribed, and you want to get off the machine sooner. And it is to do with, in part, your depression. In people that are doing peritoneal dialysis, and again, this is again a complicated slide, but just to illustrate the point, is that in people that have depression, they are 3 times more likely to get peritonitis, infection in the belly, than if you're not depressed. And the reason is simple. As those of you that may have done peritoneal dialysis, it needs to be done carefully, one step at a time. And if your mood is not good, you are more likely to skip a step or make a mistake in doing a connection and disconnection that can result in an infection. So this has been shown that people that have depression are more likely to get peritonitis. Whether it is because of missing dialysis or getting infection with PD, people that are depressed are more likely to get sick and show up in an emergency room. So that, as you can see in this bottom panel, higher these lines, more severe the depression. And the higher the lines, more likely people are to show up in an emergency room. And similarly, people that have depression are more likely to get sick enough to be admitted to the hospital. Again, all of these studies that I'm showing are in people that are on dialysis. So the health consequences of depression, I would start off by saying that the low mood is suffering enough. But because of depression, it makes it harder for people to wake up in the morning and show up for dialysis. Or if they show up for dialysis, they cannot stay for the full treatment. So people that are depressed are more likely to miss dialysis or cut their treatments short, which is not good. If people are on PD, people are more likely to get peritonitis if they have depression. They're more likely to show up in an emergency room. They're more likely to be admitted to the hospital. So as I said, that the consequences of depression are not just limited to the low mood. It affects every part of your health and your well-being. That brings us to the next question that we have. And dialysis facilities are required to screen patients for depression. Okay, so 94% of you said yes, true, and that is correct. So why is screening important? The screening is important because in the presence of kidney failure, diagnosing depression is very difficult because some of the symptoms of depression are the same as the symptoms from kidney failure, or they could be confused with side effects of the medicines people are taking. So the symptoms, people that have kidney failure have difficulty sleeping, and people with depression have difficulty sleeping. So if you're having difficulty sleeping, it could be because you have kidney failure or because you're depressed. Similarly, not having enough energy to get through the day, or not feeling hungry, so not having an appetite. All of that can happen with kidney failure as well as with depression. Medicare requires every dialysis unit to screen every patient for depression. And so facilities are required to report for every patient if the screening test for depression was positive or negative or not done. And if it is positive, whether or not there is a plan for treatment. So those of you that are on dialysis probably are still doing it once a year to find out whether or not you have depression. This is the test that is used by most dialysis units in the country, is the PHQ-2. And as I said, if you're on dialysis, you may have completed it. It is the PHQ-2 stands for Patient Health Questionnaire 2. And this is, there are two questions there. Over the last 2 weeks, how often have you been bothered by any of the following problems? Little interest or pleasure in doing things, feeling down, depressed, or hopeless. And for each one of them, there's a scale of 0 to 3, not at all, several days, more than half the days, nearly every day. So most units use an approach in which people first complete the PHQ-2. And if the score in PHQ-2 is less than 3, then nothing more needs to be done. If it is higher than 3, units would generally have people complete a longer questionnaire called PHQ-9. And if the score is 10 or higher, that suggests that a trial of treatment would be warranted. So to summarize, what more have I said? I've said that depression in and of itself causing suffering to the person. It adds to other health problems, skip dialysis, ED visits, hospitalizations, peritonitis. Depression is hard to diagnose in people with kidney failure. It helps to use a test like PHQ-2, which is now done routinely in all dialysis units in the United States, at least once a year. That brings us to our, I think this is the last question for the poll before we jump into the treatment options. It is, things that might help with depression include peer mentoring, support groups, personal goal setting, try something new, meditation, exercise, 12-step programs, psychotherapy, and medication. So these 9 options that are listed here. Okay, so the right answer is all of them. All 9 of them can be used. The two most commonly studied and commonly used treatments are psychotherapy and medication. So that will be number 8 and number 9 here are the 2 most commonly used and well-studied treatments for depression. So just this is my take on this. I mean, you can divide, there's the drug therapy, the antidepressant drug therapy that is used. There are many different types of psychotherapy or talk therapy. The most common form of talk therapy is cognitive behavioral therapy. And then there's complementary and alternative medicine. Of these, the one that is used the most often is St. John's wort. I mean, it is available in health stores and people take it. And exercise. So let me just first outline these are the challenges. So when we were doing our research study, we talked to a lot of people, a lot of patients with kidney disease. For example, we had a question posted on a Facebook page, and then we reached out to AAKP, and they reached out to their ambassadors, and we collected views from patients about the treatment of depression, and this is what we heard. We've talked about the stigma with the diagnosis of depression as in the general population. Not many studies, up until we did our study, there had not been many studies that had been done to see what treatments work for people on dialysis. There are unique challenges in delivering treatment to people on hemodialysis, so cognitive behavioral therapy or psychotherapy. If that's the treatment approach that is selected, traditionally the patient would need to go to the therapist once a week for 3 months. That will be on top of the 3 times a week that they have to go for hemodialysis. And as you know, a therapist maybe is likely to be in another place than where they are, than where you have to go for dialysis. It's not as if you can double up when going for dialysis to go for therapy. It just needs to be another appointment. For drugs, I already pointed out that patients take on average 19 pills every day, and this will add to the number of pills. And people are worried about the side effects of medication. So I'm going to talk about very quickly, show you what people have done in terms of whether or not the talk therapy works or not. So I'm going to show you, and then I'm going to have Bob share his experience about talk therapy. This is a study from Brazil. And here, rather than one-on-one therapy, they had a group of patients talk to the therapist all together. And there are advantages and disadvantages of a group therapy. If you are as a part of a group like 4 or 5 people that has a single therapist that you're talking to all together, the advantage is that you can learn from experience of others and how others have handled the challenges. But then of course there is, like, you're talking about your emotions in front of other people, and that may inhibit people from sharing what they want to do. Notwithstanding those concerns, in people that got the group therapy, the symptoms of depression got worse, got better faster. And essentially that is what it is showing. For example, that you're seeing this particular line that got better, it got much better, much faster in people that got the talk therapy. This was a study that was done in New York, in Brooklyn, New York. Rather than this being group therapy, this was one-on-one therapy. And this is the patient talking to a therapist one-on-one when they were doing dialysis. So the therapist came to the dialysis unit and talked to the patient while they were connected to the machine. And as you can see, symptoms of depression it's hard for me to, this gray bar is showing the magnitude of improvement. And the magnitude of improvement was greater in people that got the therapy when they were connected to the machine compared to people that did not get the therapy. So this kind of ties what I said earlier. If you don't get any treatment, the symptoms would fluctuate, but they would not get better. If you get treatment, they get better. So before I go on further, Bob, you received the talk therapy, I believe, in the dialysis unit.
Yes, I did.
And can you share, your concerns about privacy, about whether or not it is effective, and your thoughts around that?
Okay, well, I'm basically a private person, and I don't like to share a lot of my personal stuff with a person I don't know. But when she came, when I first met her, she came to the dialysis center, and she said, well, I want you to, open up and talk to me about your situation or what's going on and why you feel so depressed. So I opened up to her, and she kind of made me feel more comfortable about talking about different situations that were happening in my personal life. And and she said, well, I can see certain patterns, and because I've seen this before, she said, and if you're willing to try the medication, I would like to put you on there for a certain amount of time. And and she kept on coming every I think it was like every week for a while, and I got more used to talking to her about certain situations, and I started feeling better opening up to her. And I think what she was saying to me was so valuable that I took it to heart, and and to this day, I very much appreciate everything she's done for me.
All right, thank you, Bob. And we'll get to the medicines in a moment. So there are, okay. Thank you, Bob. Gosh. There have been, of course, there are a lot of medicines that are available for treating depression. And up until we did our study, there had not been very many studies that had been done. And this is just a summary of that. And there was no consistent evidence that these drugs that are used for depression, whether they will work in people on dialysis or not. So we did this study called the ASCEND study, in which what we decided to do is to compare the talk therapy, which is cognitive behavioral therapy, versus antidepressant drug therapy, to see if any one of them is better than the other. And so we did this clinical trial that we did in people doing hemodialysis. We treated that had depression. We decided to treat them for 12 weeks, either with the behavioral therapy or the drug therapy. We did this in 3 different parts of the country. We had done in Albuquerque, Dallas, Seattle, actually we went to 41 different dialysis units. In Seattle, we enrolled from the Northwest Kidney Centers, Puget Sound Kidney Centers, Olympic Peninsula Kidney Centers, DaVita. In Albuquerque, it was DCI. And in Dallas, it was DaVita and Fresenius. And so as you can see, it covered most of the large providers in the United States. In the study, we approached almost 3,000 people. Over 2,500 of them completed screening for depression. And what is interesting here, I started off by saying that 1 out of every 3 person on dialysis is depressed. In this study, when we screened over 2,500 people, 28%, so almost 30%, of people had depressive symptoms. So even today, in our communities, 1 out of every 3, almost 1 out of every 3 person at any point undergoing hemodialysis has depressive symptoms. We talked about the talk therapy or cognitive behavioral therapy already. One of the key parts of our strategy was that we gave the therapy in the dialysis unit while the patient was undergoing hemodialysis. This is, our hope in doing that was to overcome the barrier for patients to get to a therapist. So rather than asking patients to go for another appointment, we said, we'll double up when you come in for dialysis. We were mindful that there are people that may not want to have a conversation with a therapist in a public setting, like in a dialysis unit. So because concerns about the staff may hear or the patient next door may hear, we gave people the choice to do it outside the dialysis unit, but very few selected that option. People valued the convenience of getting treatment when they were connected to the machine rather than come for another appointment. And then we started the drug therapy. So with regards to the drug therapy, of course, we were mindful that this will be another pill people will have to take. We were also mindful that people on dialysis are more sensitive to get side effects from the medicine. So we started the dose of the drug at a low level, and then we changed the dose based upon periodic assessment of depressive symptoms, as well as side effects. And that process is called measurement-based care. So every 2 weeks, we'd go to the patients, assess whether or not they were having side effects, whether or not they were getting better. And if they were not having side effects, we would go up on the dose. If they were having side effects, we'd go down on the dose. So we worked with the patients to find the right dose for them. The point of this study, it's again a complex numbers that are presented there, but as you can see, the symptoms of depression got better with both. So people that got talk therapy got better, people that got the drug got better. The improvement in people that got the medication was somewhat larger than with talk therapy. So that the drug therapy was a bit more effective than the talk therapy. That does not mean that everybody should take the medicine. Both worked. Both got better. The difference was, like, the advantage of talk therapy is that it has no side effects, right? There are no physical side effects that people experience. People may be uncomfortable in talking about their emotions, like Bob talked about that. People overcome that. With the medicines, there can be side effects. None of the side effects were serious. The most common side effects that people had were either nausea and vomiting or palpitations and tremors. Those were the most common side effects that people had. But the bottom line takeaway is both treatments work. The drug was a bit ahead of the talk therapy. So I'm just gonna, Bob, maybe before I go on, if you could also share, so you said you started the talk therapy, you decided to get the drug. I know you got better with that. I want to see if you had any side effects from the drug, and if you had the experience you have had, if tomorrow you needed the medicines again, would you take it again?
Yes, I would. And I did have the side effect of nausea. I did have for a little bit, but then it went away. But yes, if I had to take this 100%, I would take it again. I would. You would think that's a miracle pill. I'm telling you, it works.
Right. Do you recall how long it took for you to feel better? Because one of the
2 weeks.
challenges, 2 weeks, right? And
2 weeks, 2 to 3 weeks.
Yeah, and that's a very important point that is to take away, is that once you start the treatment, do not expect to feel better right away. It takes
no. It's not an overnight. It's not an overnight thing. If any of you out there think that taking the pills is an overnight thing, no. It's a process. It takes at least 2 weeks, 2.5 weeks for you to feel better, and then getting back to maybe your normal self, but at least getting back to feeling better.
And then how long did you take the pills for?
A good 6 months.
6 months, yeah. And I think the important point that you made, and I want to underscore that, is that the side effect, that initially you may experience the side effect, but then it goes away.
Yes.
Right. Okay. Thanks, Bob. So let me just start with the second point, that there are a lot of people that get medicines for depression, but they are not given the medicine in doses that are high enough for them to work. So, for example, the medicine that we used for the treatment in this study is sertraline, also known as Zoloft. We started the medicine at 25 milligrams. Our goal was to go up to 200 milligrams. And on average, people, by the end of the study, were getting 150 milligrams of the drug. Many times, physicians are afraid to prescribe higher doses for people on dialysis. But if they're not prescribed higher doses, they will not work. And so I think it's important to be mindful of that if you're getting medicines for depression, that you're getting them in the doses that will work for depression. Otherwise, you'll get the side effects and no benefit. So we talked about, we did talk about the issue of stigma. We actually had to work our way through to be able to get people into the study. And I said that both medicines and CBT work, and patients should be treated, in my opinion, based on what is available, how much it may cost a patient, and what they prefer. So this is my last slide, and there'll be some, I see that there's a question already in the system. So at any time point, 1 out of every 3 person on dialysis has depression. It does not just go away, and it makes it even more difficult for patients to do what they need to do to take care of themselves. In addition to suffering from symptoms themselves, it worsens overall health. Both behavioral therapy, which I said talk therapy, CBT, and medicines improve depressive symptoms in people on dialysis. People can choose either of the two based on their choice, what is available, and what the cost of treatment would be. All right, May, there are 2 questions in the system already that I can answer, or how do you want to address the questions? All right, I'm not hearing from May, so let me answer the 3 questions already there. So let me take one at a time. So the first question is, what's the best way to get a depressed patient to seek treatment. I think because the choices and the infrastructure is different in different places, the best way would be to reach out to your healthcare professional. That healthcare professional could be your primary care physician. That healthcare professional could be your nephrologist, or it could be the social worker in the dialysis unit. It would be to contact a healthcare professional to communicate the symptoms that you're experiencing, for them then to assess and then provide you with treatment. The second question is depression worse in the first 6 months of dialysis, or does it get worse later in time? The probability of people getting depressed is similar at different time points from the time of starting dialysis. So it is challenging for people when they are starting dialysis, and that could precipitate depression. But the likelihood of having the disease depression is the same at all time points. Bob only took medication for 6 months. Do some patients take it for longer than 6 months? That's the next question. And that's similar to the next question. How long do most people need to take their medicine to get therapy to treat depression? So those are similar questions. The average number of people, the average length of time for which people need treatment at a minimum is 6 to 9 months. So that is absolutely the minimum. There are people, we've had that conversation when we were talking. So the initial treatment should be for at least 6 months. And in people that take longer to respond, it could be as long as 9 months. So Bob responded, felt better in 2 to 3 weeks. Some people may take 4 to 6 weeks to feel better. If it takes 4 to 6 weeks to get better, those people should be treated for about 9 months. There are people that complete treatment for depression and then stop treatment and depression comes back. Many of these people require medicines for the rest of their lives for depression not to come back. And so the length of treatment then depends upon how quickly they respond and whether or not it's the first episode of depression. Any additional questions?
Dr. Mehrotra, this is May. I see a question that someone has posted. I'll read it to you. Our medical director does not believe dialysis patients can benefit from antidepressants. Can you please share this information so I can forward it to him for review?
Sure, I would be happy to, yes. So May, if you could facilitate that, we can send these slides, or we can send the publication from our study that came out earlier this year. And I'll be happy to have a conversation with them if they're willing to talk to me.
Excellent. I think we can change some minds. Yes, are there any other questions, Ankar? Wonderful. And just a few minutes before 4, again, Dr. Mehrotra, thank you so much for this very, very important webinar. I want to tell all of you that are listening that when you exit this webinar, please click on a continue button that will take you to a very short evaluation form. We really want to know, in planning future webinars, to get an idea of what you liked and how you felt about this particular webinar. So if you could please complete that really short form right now, we'd really appreciate it. And we will be in touch with you about future webinars, which we'll be having throughout the fall and the winter. So thank you all for attending, and thank you for filling out the evaluation form.
Okay, thank you.
Thank you.